Welcome to Robert Wood Johnson University Hospital Somerset's Health Talk. I am Dr. Douglas Oshinsky of RWJBarnabas Health Medical Group. In accordance with social distancing due to the COVID-19 pandemic, I am hosting this show from the studio, and our guests will be joining us remotely via video conferencing. Our gastrointestinal system plays an important role in our body, helping to absorb nutrients from our food and remove the waste. In the United States, colorectal cancer is the third leading cause of cancer-related deaths in men and in women, and the second most common cause of cancer deaths when numbers for women and men are combined. It is expected to cause approximately 52,580 deaths during 2022. On today's show, we will learn more about some of the signs and symptoms of colorectal cancer, how to reduce your risk, the importance of early detection, and available treatment options. We are joined by Dr. Brendan Scully, a board-certified colon and rectal surgeon with Rutgers Robert Wood Johnson Medical School, who sees patients at Steeplechase Cancer Center at Robert Wood Johnson University Hospital, Somerset, and Robert Wood Johnson University Hospital in New Brunswick. Welcome to the show. Thank you, Dr. Scully, for being here. And just the audience would like a little introduction on who you are, for instance, medical school, residency, internship, et cetera, and where your practice is actually located.
Thank you very much for having me on. I'm very excited to be on to talk about something I'm very passionate about. So I'm Brendan Scully. I grew up in New Jersey. I went to Rutgers, New Brunswick for undergrad. And after that, I went to medical school at the Columbia College of Physicians and Surgeons in New York, where I stayed on for my general surgery residency training, during which I did a fellowship in surgical education. After my residency, I stayed on as a clinical instructor in surgery at Columbia for 1 year, and then completed a subspecialty training in colorectal surgery with the Salvati Group, which is affiliated with Robert Wood Johnson. And now I'm a clinical assistant professor at Robert Wood Johnson, and I'll be seeing patients both at Somerset Hospital mainly, as well as at the New Brunswick campus.
So you're located both at the Steeplechase Cancer Center at Robert Wood Johnson Hospital, as well as Robert Wood Johnson Hospital in New Brunswick, correct?
Yes, sir. And
just let the audience know, what is the difference between a gastroenterologist and a colon rectal surgeon?
There's a lot of overlap, and we work very closely with our gastroenterologist. They're trained in internal medicine, while we have a surgical training background, and we perform more of the surgeries that involve taking out advanced cancers, while they perform more of the endoscopic procedures and deal with more of the medical side of gastroenterology.
So they're more of the doing the imaging type of things, doing the upper endoscopy, colonoscopy. You're doing more of the surgical procedures, but you do colonoscopies yourself also.
Yes, there's a lot of overlap between our professions, and we do a lot of endoscopy procedures as well.
So let's start with the gastrointestinal system, from the mouth going all the way to the anus. Give us a little overview of what the system is, which each part functions as, and any key organs or anything else that the audience should know about.
Sure. So the gastrointestinal system, or the digestive tract, starts with your mouth, goes to your oropharynx, which is the back of your throat, to the tube that called the esophagus, which brings your food from your mouth down to your stomach, where digestion takes place. From the stomach, it goes into the small intestine, where there are several different organs that are attached to the small intestine: the liver, the gallbladder, and the pancreas, which aid in the digestion and the absorption of nutrients in the small intestine. From the small intestine, it goes into the large colon, which main function is to absorb water, to which there's 6 feet of colon, and then goes to the rectum and then to the anus, where you expel waste as stool.
So tell us a little bit about what is colorectal cancer.
Okay. So cancer in and of itself is basically an abnormal growth of tissue, where you have cells, normal cells, that go through advanced stages of growth and become, a sort of a mass or a tumor. And if for colorectal cancer, it starts typically in the lining of the colon or the rectum. And it's basically these cells that are, programmed to grow faster than normal cells and can then spread from there. Colorectal cancer is the third most common cause of cancer in America and the second leading cause of mortality or cancer death in America across both males and females. And the lifetime risk of developing colorectal cancer in the United States is about 4 or 5%. So it's pretty prevalent and a very common problem that we deal with.
So basically what we have is a very fast growth of abnormal cells in one part of the intestines. You being a colorectal surgeon, you're going to be looking more at the lower parts of the intestine. Again, the way we find it is through you or the gastroenterologist doing, if it's up in the upper parts of the stomach intestines, then we're doing the upper endoscopy. If it's in the colorectal area, we're going to do it through a colonoscopy. What are the key signs and symptoms that someone should know about for both normal and abnormal growths in the intestines, and what would be a sign that you should see someone?
So a lot of these early stage ones, unfortunately, don't come with signs and symptoms. And sometimes when you start having symptoms or signs, it's a sign that, maybe it's advanced. So some of those signs and symptoms might be either blood in your stool, or if it's higher up in the gastrointestinal tract, very dark stools or black stools, which you call melena. Other things might be, you might have weight loss. You might have a change in your bowel habits, meaning your bowels might become more frequent. They might become thinner, or they may, you may have pain with bowel movements. And those are the main signs and symptoms that we see with colorectal cancer. A lot of times we find them on screening procedures such as colonoscopy or endoscopies, as you mentioned before.
So basically the number one symptom of colorectal cancer is no symptom. It's it's basically finding it by doing a screening procedure and finding something abnormal there. Afterwards, then we're looking at things possibly change. The biggest thing is change in bowel habits, whether it's that they're becoming constipated, whether they're having increased bowel movements. When the bowel movements themselves, if they were normal in texture, that they become more solid or they become more liquidy. And then the other things we're looking at is whether the person notices a change in the color of the bowels. The change in the color, if it's red, it's blood probably very close to the end of the bowels. If it's more black, which we call melena or tarry-colored stools, then they may be much more smelly and very much more loose when they come out.
Yes, sir. And sometimes your primary doctor might notice it, that on your routine lab tests that your hemoglobin or your blood count is lower and you have what's called anemia, and that could be a sign and symptom that you have that you might have something going on in your GI tract. It might warrant for further investigation. And
what are the risks for developing colorectal cancer?
So there's stuff that we can't really modify, like family history. If you have a first-degree relative, such as a parent or a sibling that has colon cancer, that will put you at higher risk. There's some hereditary things, polyposis syndromes, and other sort of rare diseases that can lead you to have higher risk. And then there's other sort of modifiable risk factors, such as diet, eating a lot of red meats, excessive alcohol intake, smoking, having a sedentary lifestyle where you're not very active, do not get regular exercise, can all place you at higher risk of having colon and rectal cancer. And then the biggest risk factor is age itself. You're more likely to get it as you get older.
So again, important things to know is hereditary factor is very, very important. If someone in your family has a history of a colorectal cancer, it's more prudent for you to be seeing your regular doctor or your colorectal surgeon or your gastroenterologist for more screening, more frequent screening, etc. If you're on a high fat diet, something to really avoid, since that basically with all types of cancers increases the risk of cancer. Smoking, of course. And then, as you had said, it's something of the older age factor. And again, that leads to the next thing, is that up until 2 years ago, we used to say we started colorectal cancer screening at age 50, and we used to suggest, colonoscopies at age 50, and then based on the results of that colonoscopy, initially, years ago, it used to be every 3 to 5 years, then it went to every 7 to 10 years, except if there was something found on the colonoscopy, and then in between, the use of either a Cologuard or a fecal immunochemistry testing. What are the current guidelines, now that everything's been updated?
Yeah, so now it's recommended that your average risk person, somebody who does not have a family history, or first-degree relative with colon cancer, starts to screen at 45 instead of 50. This is because we're starting to see colon and rectal cancers in a younger population, and we want to catch them earlier, either before they develop into cancer or when they're earlier stage. Depending on what is found on that colonoscopy and how well your prep is and how well they're able to visualize the inside of your colon, determines when you might need to get another one. If you have a family history, if you have a parent or a sibling with colon cancer, it's recommended that you start at age 40 or 10 years before your family member's diagnosis. So if they were diagnosed at age 45, for example, you'd want to get your first screening colonoscopy at age 35, and you'd want to have shorter intervals. You wouldn't want to wait to 10 years that an average risk person might want to wait. You might want to get it every 3 to 5 years or sooner.
And the important thing about doing the colonoscopy is that you can actually see what's going on. And if it's something small like a precancerous polyp, you're actually able to remove it at the same time that you're screening the person. And that's one of the few cancers that we can actually say, or the precancers that we can actually say we can actually stop something that easily.
Yes, that's why it's so important to get screened. The colonoscopy, we say it's both diagnostic, being able to see the lesions, and therapeutic, as you said. And those other tests are really just screening tests. And if you have a positive Cologuard, the recommendation is that you go forward with the colonoscopy as well. So we want people to get screened one way or the other, but the colonoscopy is really the one test that can take care of the problem once it's identified, if there is one.
So the gold standard of care is the colonoscopy.
Yes,
now,
sir.
of course, and again, that's very important, especially if you have the family history. If you don't have the family history and there's any qualms about it, we do have the stool FIT test or the stool Cologuard test, and that's very good screening for people who do not have the family history and who have average risk of colorectal cancers, with the understanding that if it comes up positive, it should be followed up by a colonoscopy.
Correct.
And if they're doing a stool FIT test, stool fecal immunotest on it, it should be done every year, while if they're doing the Cologuard, it should be done every 2 to 3 years.
Approximately, yep.
So
that's right.
It's important that the people understand how important the screening is, with each screen being done individually based on the person's family history and any previous colorectal cancer screenings that they've previously had.
That's correct. I mean, and if you have a family history, the Cologuard is really not appropriate for you. You really should get a colonoscopy. And none of these tests are perfect, but taken together, they can reduce your risk and help identify things earlier rather than later.
And if you do find a colorectal abnormality, how is it treated, and any surgical options afterwards?
So if we find something on colonoscopy, we try to remove it during the colonoscopy and remove it completely. And if it's just a polyp, which is a precancerous lesion, which we're concerned about developing into a cancer, those can be removed with colonoscopy, and you may just need further, more frequent colonoscopies depending on what the findings are, based on pathology and how many you have. If you have a cancer that's found on colonoscopy, the general treatment is a surgical resection for colon cancer. And the first thing that we do before we rush to surgery is we like to stage what we call stage the patient, which means getting a set of blood tests as well as imaging studies such as CAT scans to see how if the cancer is spread anywhere else, and guide our surgical management. For colon cancer, our surgeries are basically a segmental resection, or taking out portions of the colon based on where the cancer is and the blood supply and the lymph nodes that drain that area, so that we can get out any cancers and properly stage them to see if they're involved with the lymph nodes. And that's the mainstay for colon cancer. For rectal cancer, it's a little more nuanced, and there may be, sometimes we do chemotherapy and radiation first based on staging before proceeding to surgery, or if you need surgery at all.
So again, what we're looking at first is if it's a polyp or a precancerous, that's something that we can possibly or probably be able to remove during the colonoscopy.
Right.
And again, the nice thing is that since they're in there, they can do a polypectomy removal, they can freeze it, they can pull it out, and then they can send it off on pathology. And if there's anything there, that's when we follow up with a more frequent colonoscopy just to make sure, one, that all of the polyps are removed and that nothing forms afterwards. If it's something more than a polyp, then that's when we end up doing the referral over to you, and which leads us into the next thing. Not only are you a colorectal surgeon, but you're also part of Rutgers Robert Wood Johnson Medical School, and you see patients at the Steeplechase Cancer Center. So tell us about the services that the Steeplechase Cancer Center offers for colorectal cancers.
Yeah, so here we have what we call a multidisciplinary team approach, which means that it's not your gastroenterologist and myself talking and coming up with a plan. It's myself, the gastroenterologist, sorry, the lights went out in here. The gastroenterologist, the radiologist, the pathologist, all of us working together as a team, oftentimes with your primary doctor so that they're on the same page, coming up with the best plan to treat your cancer. And that may be surgical resection first, chemotherapy first, and then once we proceed with that plan, following up again to determine, the proper surveillance protocols and the next steps as well. So it's all of us working together as part of a team. It's a real team-based approach that we have here. And additionally, we also have a lot of other, ancillary staff to help us out. We have support groups and social workers that can help with the, some of the issues, dealing with colon cancer, and be an invaluable resource to our patients going forward as they, go through their cancer fight.
So the important thing is someone like you, as being part of the Steeplechase Cancer Center, as part of RWJBarnabas Somerset Hospital, you have the whole multidisciplinary team together. You have the oncologist, you have the radiologist, you have the gastroenterologist, the colorectal surgeons, you have the physical therapists, you have the nutritionists, you have the nurses, you have the nurse practitioners, you have the whole team together. And you also have on Wednesdays and Fridays, you have rounds where everyone they pick the patients up and everyone presents what they see is going on with the patient, what they think is the best cause, best treatment of it, and you come up as a team with what you believe is the best possible means to treat the patient, take care of the patient, and follow the patient up afterwards.
Yeah, the patient's at the center of our approach, and our goal is to get our patients the best care possible, so that they can get through this fight and live a long and happy life once we get them through it. And so we have all of us together coming up to a consensus to figure out what the best things are for each individual patient, because everybody's problem is a little bit unique, and this way we can all come together to come up with a consensus.
And what this also allows is it allows you to get the best possible care in the same community that you're living in. So if you do need any services afterwards, you're able to easily access those services. Plus, any follow-up treatment is done at the local hospital, where again, it makes it much easier to get in and out. It's much easier to do that than to try to drive into New York City, find a parking spot and go into one of those hospitals. You're getting the exact same treatment here under the auspices of terrific, physicians, protocols. You're following everything that they would have done in New York, but you're doing it at the Steeplechase Cancer Center, allowing the patient and the family the best possible care.
Yeah, I mean, that's a great point, Doctor. I trained in New York City, at Columbia, and we had patients coming from all over, and they got great care. But a lot of their complaints were having to come back in the parking and whatnot. And we feel very strongly that we can provide that same level of care here in New Jersey. The Steeplechase Cancer Center is a great resource for our community, and it's also affiliated with the Rutgers Cancer Institute of New Jersey, which has access to a lot of the clinical trials and cutting edge treatments, should they be required or should patients be eligible. So we have that great resource as well. And really it's, subspecialty care, people that, live, breathe, eat, cancer care and taking care of New Jersey, citizens.
So again, such important that you just said. Not only do we have the team approach at the Steeplechase Cancer Center at RWJBarnabas Somerset Hospital, but you also have the partnership with the Rutgers Cancer Institute of New Jersey, allowing state-of-the-art treatment if they require any clinical trials, clinical protocols. It is the Rutgers Cancer Institute that it runs this, and with their partnership, you're able to give the patient the best possible treatment for their disease.
Yeah. I mean, it's a great resource, and it's top of the line cancer care that we're providing here in New Jersey. And we're very proud of that. And we have this, the training to provide the technical expertise and the resources to give that back to the people of New Jersey.
And again, it's important not only the providers themselves, but it's also everyone affiliated with the providers. It's everyone affiliated with the Steeplechase Cancer Center, everyone affiliated with the Rutgers Cancer Institute. So if you do need support, unfortunately, sometimes we do require, having a colostomy for a couple of weeks in order for things to heal, and then we're able to reattach things. You have the backup of everyone at the Steeplechase Cancer Center that helps you get through those tough times, because that is a tough time for someone who's never had something like that happen. So you've got the social services, you've got the nurses, you've got everyone involved in it.
Yeah, I mean, and we try to avoid giving people ostomies, and that's one of the big concerns for our patients is, am I going to have a bag afterwards? And we have the surgical expertise, the technical expertise, and the understanding of the disease to avoid it when we can, but also managing it and with the support system to help patients manage it and get it through them so that we can eventually reverse them if possible.
Again, based on your expertise, based on the expertise at the Steeplechase Cancer Center, based on the expertise at the Cancer Institute of New Jersey, you allow the patient to have the best possible care. If they need the ostomy, it's basically done to help them. And most of the time when they do need the ostomy, we're able to reverse it afterwards based on what the cancer is and what the final outcome is. You also have the hematologist, oncologist involved. You have the radiation oncologist involved if necessary. So you have the whole gambit of a whole treatment system working for that patient.
Yeah, I mean, and how we manage cancer is changing at daily, it seems like. And so we're on top of all the new trials. We're on top of all the new medications. And sometimes, we're able to offer patients a non-operative approach. And as a surgeon, that's one of the great things that we when we can tell a patient, hey, you don't need an operation, or we can preserve your organ and we'll watch it closely, versus those who need an operation. And we have the team-based approach to figure out which patients are best and which approach fits each patient.
So I'm an internist and I've got a patient who has a colorectal cancer. What should I do for that patient? What should I inform them I'm doing when I am consulting with you? And what should the patient expect?
Yeah, so I mean, you have them refer them to me, and I'll plug them into our system and present them at our meetings, and have them set up with our oncologist and our radiologist. Once somebody's diagnosed with a colon or rectal cancer, typically we get CAT scans or CT scans to get better images. If it's a rectal cancer, we often get an MRI as well as some blood tests to figure out, what stage this cancer is and what the next steps in treatment are, whether that's straight to surgery, radiation, or chemotherapy first, and the next steps going forward.
The other thing that we haven't mentioned, which is again part of the Steeplechase Cancer Center, is that you have nurse navigators. who are
Yes, sir.
basically the best captain of the ship for the patient. It's someone who gives them the person their phone number and is able to help guide them through the whole maze that they're going to be going through, and helps guide them what is the way to make everything go appropriately, how to make your appointments, how to follow up, how to do things as an outpatient. It's something that basically if I had sent them to just a gastroenterologist, I wouldn't have. So that whole team approach at the Steeplechase Cancer Center at RWJBarnabas Somerset allows me to access that person, and allows the patient, again, to get the best possible care for their disease.
Yeah, I mean, once somebody gets a diagnosis of cancer, it's a life-altering diagnosis, and a lot of stress, a lot of family members asking questions, a lot of uncertainty, and we try to eliminate some of the things that we can't eliminate, such as the stress of trying to figure out where to go or how to get in contact with the doctors. When you come and see us, we try to arrange so that you're seeing me as a surgeon and then you're seeing the oncologist or the radiation oncologist all at the same time, so that we can sort of coordinate your care and take some of the burden that we can and modify that as much as we can to make this process as smooth as possible.
Again, allowing the patient to have the best possible care at a local facility, but getting the best possible care, the same care that they would be getting if they drove into New York or drove to one of the other tertiary care facilities throughout the United States. Basically, we're giving them tertiary care support, plus we're getting the partnership of the Rutgers Cancer Institute at a local setting.
Yeah, I mean, subspecialty training, technical expertise, access to clinical trials, all that here in New Jersey.
So with only a few minutes left, give us a conclusion of what the key messages the audience should know.
I think the key message is to get screened. If you're 45 or above and you hadn't had a colonoscopy, you need to have a colonoscopy. Again, we can intervene before it develops into cancer if you have something. We can catch it earlier stage before it becomes more advanced. And you'll have better outcomes, and your risk of sort of mortality if you are diagnosed with cancer are much lower if you get screened. If you have a family history, you need to get screened maybe a little bit earlier, and you should discuss that with your primary care physician. And then again, try to reduce the risk that you can. Live a healthy lifestyle, avoid too much red meats, exercise regularly, to sort of modify some of those risk factors that you can. To reduce your risk going forward.
So again, important things. In this instance, ignorance is not bliss. What you want to do is you want to make sure, number one, if there is a family history, make sure your primary care doctor knows about it and be referred to a gastroenterologist or a colorectal cancer surgeon such as yourself as quickly as possible. Make sure you follow up as quickly as possible. If you have changes in your bowels, make sure you bring it up to your primary care doctor and or your gastroenterologist. If you can reduce your risk of cancers, not just only colorectal cancers, but all cancers, by increasing the vegetarian part of your diet, reducing the red meats, reducing any type of red meats on barbecues and things like that, increasing fruits, vegetables, healthier diet, more exercise, and basically, hopefully, things turn out better by doing things like that.
Yeah, you increase I mean, it's not just colon and rectal cancer. If you leave that healthier lifestyle, you're going to increase your chances of a longer life and a healthier life exponentially.
And also, of course, the one last thing is if you do smoke, stop smoking.
Yes, absolutely. Very important to do that as well.
Thank you, Dr. Scully, for being here. Thank you for your expertise. Thank you for what you do at the Steeplechase Cancer Center of RWJBarnabas Medical Center, Somerset, as well as at the Rutgers Medical School. Thank you for everything.
I appreciate you having me on. Thank you very much.
This concludes today's episode of Health Talk. Please remember that the opinions expressed here today by our medical expert are not a substitute for medical advice from your own physician. If you need a physician, please call us at 888-724-7123. For more information about cancer services at Robert Wood Johnson University Hospital, Somerset, please visit us at www.rwjbh.org/Somerset.